All right, let's get right into it. Today, we're opening up the playbook for one of the most intense situations in the ICU, managing a patient in shock. We're going to break down how to use vasopressors with a clear, step-by-step guide for when things get really serious. Let's go.
So, picture this. The alarms are screaming, your patient's blood pressure is in the basement, and you have to do something, right now. This is that moment where having a solid, structured game plan makes all the difference. So what's your opening play?
Well, before you can make a move, you gotta know what you're up against. Shock, at its core, is a failure of the circulatory system. The body just can't get enough oxygen to the tissues. And vasopressors, they're our most powerful tools to get that blood pressure back up and restore that vital blood flow to the organs.
Okay, this right here is the key to understanding almost all of these drugs. Just think of it like this. Alpha receptors squeeze the blood vessels, which cranks up what we call systemic vascular resistance, or SVR. On the other side, beta receptors make the heart pump harder and faster, which boosts cardiac output. Squeeze versus pump. If you get that, you're going to get everything that follows.
So here it is. Our game plan boiled down to 3 essential steps. 1. We always start with our workhorse norepinephrine. 2. If that's not cutting it, we call in for backup with vasopressin. And 3. If things are still looking bad, we open up the specialist toolbox. This is the roadmap for everything we're about to cover.
So let's talk about that first move, norepinephrine, which you'll almost always hear called by its brand name, Levophed. This is, without a doubt, your starting player for pretty much every kind of shock you're ever going to see.
So why is Levo number 1? Well, it just has this fantastic balance. It's mostly an alpha agonist, so you get that powerful squeeze you need to raise the blood pressure. But it's also got a little bit of beta effect, so it gives the heart a little extra pump too. That versatility is what makes it the go-to for all kinds of shock. And you'll typically be dosing it somewhere between 0.01 and 0.50 mics per kilo per minute.
Now, I want you to burn this number into your brain. 0.1 mics per kilo per minute. This isn't just some random number. It's a critical line in the sand. It's the point where our whole way of thinking has to shift, and we need to start asking some really important questions.
The second that norepinephrine drip crosses that 0.1 threshold, 2 big safety alarms should be going off in your head. First, you need to seriously consider getting a central line. Why? Because if that high-dose pressor leaks out of a regular IV, it can cause devastating tissue damage. Second, you need to consider holding tube feeds. High-pressure doses shunt blood away from the gut to save the vital organs, and if you try to make the gut digest food without blood flow, you risk killing the bowel. So remember, 0.1 is your trigger. Think central line and protect the gut.
Okay, so you've got the norepinephrine going, you're titrating it up, but the blood pressure is still stubbornly low. It's time to call for backup. And our second-line agent is vasopressin.
Vasopressin is a really unique player on the team. See, it doesn't mess with alpha and beta receptors like the others. It works on its own system, stimulating V1 receptors on blood vessels. It still gives you that squeeze, that vasoconstriction, but it does it through a totally different door. It's like you're attacking the problem from a whole new angle.
So why is this different pathway so incredibly useful? Well, a couple reasons. First, you don't really titrate vasopressin. It's a fixed dose. But more importantly, when patients get really sick with shock, their blood becomes acidic. And that acidic environment makes pressors like norepinephrine work less effectively. Vasopressin, though, it couldn't care less about the pH. It works just fine, which makes it a lifesaver in the sickest of the sick.
Now you're going to hear people talk about vasopressin having a levo-sparing effect. And what that means is, once you start it, you can often turn down the dose of the norepinephrine, or levo. And you'll see this happen all the time. But it's really important to know that while it's a real effect, no study has ever shown that it actually improves mortality. It just helps you need less of that first-line drug.
All right, we've deployed our first and second-line agents, but the patient is still in what we call refractory shock. This is when we have to crack open the specialist toolbox and pick a very specific tool for a very specific job.
Our 2 main specialists are phenylephrine and epinephrine. Think of phenylephrine as a pure alpha agonist. It is all squeeze, no pump. All it does is clamp down on blood vessels, period. Epinephrine is a bit more complicated. At low doses, it's mostly a beta drug, all about the pump. But as you crank up the dose, the alpha effects kick in and you start getting more and more squeeze.
So how in the world do you choose between them? Well, it often comes down to the heart rate. If your patient needs that squeeze, but their heart is already racing, phenylephrine is a great choice because it won't speed it up any further. But you have to be careful.
That intense squeeze can cause the heart rate to drop, which we call a reflex bradycardia. On the flip side, if the blood pressure is low and the heart rate is slow, epinephrine is perfect, because its beta effects will bring both of them right up.
So far, we've been laser-focused on the squeeze. But what if the problem isn't the blood vessels? What if the problem is the pump itself? That's what we see in cardiogenic shock, when the heart is failing. And for that job, we need a whole different class of drugs called inotropes.
You know, it's funny, if we were having this conversation 15 years ago, we'd be talking a lot about dopamine. It used to be considered a first-line pressor. But then, this huge game-changing study called the SOAP-2 trial came out, and what it found was pretty shocking. Dopamine caused a way higher rate of dangerous heart rhythms, or arrhythmias. And just like that, it got demoted from the starting lineup.
So with dopamine on the bench, how do we pick our inotrope today? The choice usually comes down to the patient's SVR, how clamped down their blood vessels are. If their SVR is low, dopamine can still be a decent choice. If the SVR is normal, dobutamine is a great go-to. But if the vessels are already super tight with a high SVR, milrinone is an excellent pick because it actually helps relax them a bit. Just remember, milrinone is cleared by the kidneys, so you absolutely want to avoid it in patients with kidney failure.
Okay, you're now on 3, maybe even 4 different pressors. You've used up all your standard plays. This is when you reach for the Hail Mary, and that's stress dose steroids.
What we're talking about here is giving something like hydrocortisone, maybe 50 milligrams every 6 hours. But let's be crystal clear about the evidence. Stress dose steroids have never been shown to have any impact on mortality. They don't save more lives. So why do we do it? Well, there is some evidence that they might lead to a faster resolution of shock, which helps you get the patients off all these pressors sooner.
So after all that, what's the big idea? The crucial point is that you don't have to just make things up in a crisis. There's a logical, evidence-based, step-by-step playbook for how to escalate support when your patient is in shock.
And here it is, the whole strategy in a nutshell. Step 1, start with your versatile workhorse norepinephrine. Step 2, add vasopressin for its unique pH-independent effects. Step 3, pull out a specialist like epinephrine, phenylephrine, or an inotrope to target the specific problem. It turns chaos into a clear, manageable strategy.
Look, knowing the playbook is absolutely the first and most critical step. But the real art of this, the mastery of intensive care, is using that playbook to anticipate what the patient is going to do